This is Dr. Tawari.
And this is Dr. Kochak.
And you're listening to the Breast Podcast Ever. Broadcasting from Columbus, Ohio, we'll be talking about plastic surgery procedures focusing on only the breast.
Ranging from breast reconstruction to breast enhancement and reduction, we'll cover everything you ever wanted to know about the breast.
Well, hello, everybody. Welcome to the Breast Podcast Ever. And this is Dr. Tawari here. I'm very excited to present Dr. Achint Choksy, who is a specialist in many areas of integrative medicine as well as general medicine. He also has the distinction of being my personal physician, so that's how much I trust him with my own health. And Achint, welcome to the Breast Podcast Ever.
Thank you. Thank you so much for having me here. It's a pleasure.
Yeah, well, Dr. Choksy and I first met at a conference probably about 2 years ago, and I remember it very clearly. He sort of got up to the front of the speakers area and talked a lot about his practice and how he has combined a lot of Western medicine with almost an Eastern mind frame. And I thought that would be a good place to start because I think a lot of patients turn to their doctors not only for conventional treatment, but also for strategies to improve their wellness, their well-being, to then ultimately prevent disease later on.
Yeah, that's very interesting that you say that. Yeah, it's a kind of unique practice. So when we talk about Western medicine with Eastern mindset, and there's a book. The name of the book is Western Body, Eastern Mind. One of the most phenomenal books that I've read, and I've only read half of it, but it blows my mind. It's so detailed. So what does that mean to be a Western doctor with Eastern mind? I was trained as a Western doctor. Then I became a yoga teacher. Well, I went to India and spent 4 months in monastery and yoga centers over there and literally lived in a 10 by 10 cell and did yoga for 14 hours a day. So that kind of changed my perspective on looking at people. Instead of looking at people in cells, I started looking at energy. And then it dawned on me and it made sense that disease, the definition of disease changed. So disease is nothing more than an energy change that we don't like. If it's diabetes, it's energy change in pancreas and in the blood because of sugar. It changes our energy. If we don't like it, we call it diabetes. If we like it, then we don't.
So talk about that a little bit. What do you mean by energy? Because I think that's a difficult term for people to wrap their heads around when we like to think of things in sort of such a quantifiable framework.
Yeah, it's super simple. So you just have to keep breaking it down a little bit more and more. So you and I were both trained looking at receptors and maybe proteins, maybe some molecules and how they bind and how they cause effect. If we go down a little bit more in detail, what is that molecule made up of? Some type of element, right? We're made up of carbon and hydrogen and oxygen and nitrogen and phosphorus. These are the 5 elements, and they make up our DNA. If we go in a little bit more in detail into those elements themselves, how are they bound with each other? DNA has a lot of nitrogen and carbon and hydrogens and oxygens are there and phosphorus that connects the DNA base pairs. When you look at them even in more detail, they're all surrounded by certain type of electrons, right? And that electron has certain type of energy because it rotates around. Carbon has 4, oxygen has 6 plus 2 to be stable in its valence form. So if you keep breaking it down into its finer particle, this whole concept of medicine is all about understanding the electron transfer, which is what we call redox. Positive goes to negative, negative goes to positive, and it's all interactions.
You're challenging me with my inorganic chemistry from college.
Yeah, I had to. It's been, I didn't do that well back in college in organic chemistry. Somehow I made it, but then once med school hit, everything just kind of started coming back together. And then,
well, it's interesting because you're applying these concepts that we all learned, but if we're going to be honest with ourselves, there was never really a practical application for us in our understanding of pharmacology, in our understanding of physiology. We never really relied on these concepts of inorganic chemistry and electrons and protons and sort of the energy that's so fundamental to any molecular structure.
Yeah, that's absolutely true. I mean, we had very little bit of understanding in cardiology, whether learning the cell potential, -90 to -30 to 120. I mean, we learned a little bit about sodium potassium channels, but then we need to go deep down into oxidative stress. And oxidative stress is nothing more than an electron transfer. An oxygen molecule becomes a radical, and that's inflammation. And when we start understanding those concepts a little bit more and more and more in detail, everything that we do is about positives and negatives. It's good and bad. It's day and night. It's up and down. It's sun and moon, right? So everything is just binary, zeros and ones, right? Even the computers run on zeros and ones, all the programming. So that's how our entire body is structured in electrons, positives and negative electrons that keep us balanced.
So break this down in the context of inflammation, because that's something that we talk a lot about in our practice when it comes to patients who have implant-associated problems or patients that develop a breast cancer, and we're talking about the healing phase, the inflammation associated with surgery. Break that down for our patients in a way that you see it in your practice.
Okay. All of us are looking for energy, and energy, if we have more amount of energy, we become happy. In mitochondria transfers electrons and makes ATP, which is an energy form, right? It's energy currency in the body. When we talk about inflammation, let's backtrack. Mitochondria needs electrons. So let's get this straight in our body. The mitochondria needs extra electrons to transfer in electron transport chain to make ATP. The source can be protein, fats, and carbs, goes through the different processes in Krebs cycle and makes ATP at the very end after it goes to ETC. Now, electrons are needed. So that's one thing. On the other side, we lose electrons when we become very acidic. Acidics are hydrogen ions, right? Acidic is everything that is positive, extra protons. Why do we talk about extra protons? Because inflammation, whether it's done through giving away electrons or whether it's done through by giving away electrons or gaining positive charges, is all inflammation. So in the most layman's term, when we become acidic, our oxidative stress goes up. And when we talk about oxidative stress, we're literally talking about oxygen molecule not having enough electron in its outer shell. So it becomes very toxic. It wants to be stable, right? If I'm very happy with, let's just say 3 shirts and a pant, and if I don't get one of the shirts, I'm going to feel unhappy. Well, that's what the oxygen feels. Oxygen has a certain amount of protons. It needs a certain amount of electrons to be in a stable form. When it doesn't have that, then it says, hey, I need electrons. Where do I get it from? So it goes around our body, goes through our blood vessels, trying to get electrons from other places, whether it's other cells, whether it's red blood cells, whether it's other red blood cells, other immune cells. It will try to pull those electrons out of it. And what's inside the cells? Mitochondria, which has the extra electrons. So when we have extra inflammation, it will pull away your electrons from this mitochondrial source, which is the reservoir of electrons, and it pulls it away. So as it pulls it away, this oxygen, this inflammation is causing damage, and it's pulling away. So now you have to fix this damage that it's doing inside the blood vessels or in other cells or in other organs. And 2, it slows down your actual energy production. So that's what inflammation is. Anything that takes away your extra electrons, right? When we learned about back in chemistry 101 or biochemistry 101 in med school, we talked about electron potential or membrane potential of every cell, which is -90. In cancer world, we talk about anything that goes towards positive, right? -60, -50, -40, -30. The more positive the cells become, the more cancerous they are. Well, that's because it doesn't have enough electrons. The second we start giving our body enough electrons, that's where antioxidants come in, right? If you take a lot of berries, you're going to get a lot of electrons.
What are some of these causative factors that lead to this oxidative stress? And as you were saying with berries and other agents, what are things that we can do, whether it's diet or other treatment mechanisms, to improve our kind of negative positive balance?
Yeah, so I do a lot of genetic testing as well, right? So a lot of times, sometimes if somebody has, let's say, just give you an example, MTHFR gene mutation, that might affect their folate production and conversion of folate into active folate. And that might put them at an increased risk of slowing down some of these pathways that where folate is required. If you slow things down, then you can't detox, you can't function your normal cells well, then things will back up, and that will cause stress to your body, and that will lead to inflammation in many cases. So there are a lot of genetic factors that can lead to inflammation. There are normal behavior patterns, the way we are. Sometimes we only breathe shallow breathing. We're not even bringing in enough oxygen in our body. So if you don't bring in enough oxygen or red blood cells, normally it holds on to 4, right? 1, 2, 3, and 4. And right here is iron. So there are 4 oxygen molecules around an iron core, and we call that a heme molecule, hemoglobin. Well, if these oxygen molecules, if you're not breathing well and deep enough and getting rid of carbon dioxide, then we become acidic, right? We talk about this in ICU setting. When somebody has a lot of carbon dioxide, they're acidic. Well, to get rid of carbon dioxide, you just have to breathe deeply and fully. And these oxygens that are sitting in every red blood cells, they're not going to go bind to the next red blood cells. Because the second they bind to the next red blood cells, these 2 oxygens are now preoccupied. Even though you have a total of 8 red blood cells, you're only going to be able to deliver the 2 on the ends, right? 2 that are on the ends.
I want to stick on this point for a second, because one thing that we see very commonly among our patients who have had an implant placed underneath the muscle, probably the most common complaint that I hear is that I have trouble breathing. I have trouble taking in deep breaths. And I've never had a clear sense of the physiological impact of this, but my instinct is that there is a physiological impact. So given that this is a common complaint, and given what you've just said, what do you think patients who have this trouble with deep breathing and relaxed breathing are experiencing as a result of those restrictions in their breathing? So in other words, people have trouble taking a deep breath because of their implants underneath the muscle. Very common complaint.
Right.
How do you think that manifests? You talked a little bit about the ability. It keeps you in a more acidic state because you can't breathe off the CO2. How do you think that it impacts people's physiology and their everyday activities?
Yeah, so if you're not breathing well, breathing brings in, from the Eastern perspective, we talk about prana. Prana is your life force. From our normal Western conventional perspective, we're talking about actual oxygen. Oxygen is alkalizing to the body when it's in right quantity. And when we get rid of the carbon dioxide, we become less acidic. So when somebody's breathing in, if their mechanism of breathing is shallow, maybe it's because they're not completely fully able to expand and inhale deeply, they're not only training their muscles to not get enough oxygen, they will shrink because we're creatures of habit, but that leads to long-term sustain a practice, a type of a practice of breathing. And then we really have to train them to undo their practice. Sometimes some people are hunched forward and they won't be able to breathe well. Some people have a lot of big breasts, or some people have a lot of, ventilation syndrome, right? We talk about hypoventilation syndrome, or it may be related to obesity, or it may be related to implants, or it could be related to just having more weight on your body. And sometimes it's related to just wearing really tight clothing, right? A lot of sport bras. In that hypoventilation syndrome, that will create a certain type of pattern. And that's going to put you into a sympathetic zone. Because the further we inhale, the faster we get into sympathetic zone. The longer we exhale, the faster we get into parasympathetic zone. So whenever we are training somebody for heart rate variability training on the machine, when they're getting trained, we're training them to inhale 3 seconds, exhale 6. Inhale 3, exhale 5 to 6 seconds. And it gives you inhale and exhale, a long curve, like inhale and exhale. So what is that doing to the body? It's bringing the heart rate down by increasing the parasympathetic exhalation phase. And sometimes when you feel that there's something constricting, if I'm supposed to open my finger wide, but then there's something that's blocking it, well, it's not going to let me open my finger completely. And that's what's happening to all these rib cages sometimes.
I love what you're saying because it is a thought process that I have had as well. And I want to take you through my thought process and see what you think. So again, very common for us to have patients who have submuscular implants. One of their most common complaints is I cannot breathe. Probably the second most common complaint is I feel like I have a lot of anxiety. Alongside that anxiety, I've heard heart palpitations. I've heard trouble swallowing. I've heard even, cognitive issues. And I think most things in medicine, there's an underlying mechanism that ties a lot of symptoms together. And my own hypothesis here is that this inability to take relaxing breaths, as you've said, is so common in Eastern philosophy. I mean, so much of yoga and meditation is controlling your breathing pattern. And if this does put you into a sympathetic fight or flight type state, I think at some level ties some of those symptoms that people complain about to one root cause, which is this inhalation exhalation imbalance. And I'll go one step further because I just thought of it that you were in the time that you were talking, is if people develop these types of breathing patterns, it makes sense that you would have to retrain your breathing pattern. And a lot of patients talk about a quote unquote detoxification period after their implants are removed. What if it has little to do with the implant removal and more to do with this adapting your breathing back to a normal breathing pattern?
Yeah, you're absolutely right. I'd
love to hear your thoughts on that, because this is something that I've been sort of kicking around in my brain for quite some time.
Yeah. So after any type of surgical procedures, right, whether it's a cabbage, open heart procedure, lung implants, so any kind of lung surgeries, breast surgeries, anything that relates to your mid-thorax that affects your ability to breathe, whether it's a hernia, abdominal hernias can affect the diaphragm sometimes. After that, the main focus in terms of rehab, from my perspective, I put the most amount of emphasis on the breathing. Because if we can help somebody breathe, and that's what, the spirometry, right? And the rehab, we give those little
incentive
spirometries, but the emphasis isn't placed on it. We just write an order and say, hey, look, do it 3 times a day or 5 minutes every hour. But the amount of emphasis that we need to put on it to increase their long-term exhalation will put them into parasympathetic. Now, here's what happens, right? If we take sympathetic and parasympathetic tone, as soon as we apply that sympathetic tone into the gut, having more carbon dioxide into a sympathetic tone leads to leaky gut syndrome. It leads to IL-1 release, leads to IL-6 releases, TNF-alpha releases. Now you have leaky gut syndrome. It affects your microbiome. Well, if the microbiome is not there, over time, you're going to have less neurotransmitters because 90% of neurotransmitters come from the gut. So if you don't have neurotransmitters, then post-op, somebody who has gone through a antibiotic course or even for 1 day, right? You've given them Cipro or cephalexin or something, or ampicillin for 1 shot, preventive surgery for prophylaxis for surgery. And if somebody gets some post-op infection or something, well, the gut biome is going to be gone. Now they're going to come back within 2 to 4 weeks with heart palpitations because now they don't have enough neurotransmitters because their brain is completely guiding the signals that it's supposed to guide, whether it's through vagus nerve or sympathetic tone, SA node, every node, all of them are affected through our gut and brain connection. So whenever my approach is to look at the person and look at their symptoms and say, okay, what just happened? How did it mess up your gut if it's a neuro symptoms? If it's a heart and the lung symptoms, let's change your breathing because within 10 breaths, we can change your heart rate and it will drop by 5 to 10 beats. Like right now, if I'm measuring my heart rate, if I start breathing in that pattern, then it will start dropping my heart rate really fast. So, the goal, there are studies out there that says we want to be around 60 to 65, anything over 65 or 64, every 4 beats over 64 beats per heart rate is inflammatory. There's inflammation going on. So we want to stay less than 64, but somewhere in that range. If you're there, then it's really good. And that's something that we have to focus on. All of these things are obviously reversible. The healing speed will get better as soon as we put them into a parasympathetic tone. They will automatically feel better. Their amount of energy expenditure will drop, metabolic speed will drop, so that the body will focus all those resources straight into the healing process rather than using up for other bodily areas.
One thing I think that would be a real service for patients, and it seems like a crazy thing to ask, but I know you'll understand what I'm asking, is teach people how to breathe.
Mm-hmm.
And it seems like we should all know how to breathe. We don't all know how to breathe.
Yeah. You want me to teach people how to breathe?
Yes, I think it would be great.
All right, so we can do this. How about this? Though sometimes what I do is, you'll notice, even right now when I'm talking to you, I'll take a deep breath and then I'll talk. And I'm in that business of talking a lot. So then it kind of works out for me. But for everybody else who's not, I want you to think in this manner, right? You're taking in a deep breath in count of 3. So exhale all the way out. Now inhale from let's look at this. Inhale, 1, 2, 3. So your inhale in that manner. So air is going in from the bottom and up, and you're exhaling in 6. So I'll count it again. Inhale, 1, 2, 3. Exhale, 6, 5, 4, 3, 2, 1. Inhale, 1, 2, 3. Exhale, 6, 5, 4, 3, 2, 1. And this is a very simple form of breathing. It puts you into a sympathetic tone. If you're driving, I would say don't do it while driving, because it's going to put you into a parasympathetic tone. I misspoke. It's going to put you into parasympathetic
because you're making yourself less acidotic with a prolonged expiration phase. You're not retaining CO2.
Right. So I would keep this type of breathing going even while walking or talking to somebody, or when you're typing on the computer. If you notice yourself that you're not breathing well, just inhale 3, 2, 1 and exhale really slowly. So counting is hard. So I don't count. I'm not always counting my breath. I've practiced over and over again where I know that I have to breathe through.
I think it's important because I do believe that many of the problems that we see with, as you were saying, trunk surgery have to do with pain and discomfort that affect our normal breathing patterns. And I think even post-surgically, those habits linger. And unless there's a conscious sort of way to address it, I think that those habits, create patterns that lead to maybe things like anxiety, maybe these other issues in the gut biome. I think a lot of this is not something that we have quantifiable evidence to justify, but I also think that it makes a lot of intuitive sense to me from a physiological basis.
We know, right, from PM&R perspective and a lot of rehab research studies, it shows that 1 day of hospital stay will decrease your muscle mass by 10 to 20%. 2 days of hospital stay will decrease your muscle mass. Somebody will lose muscle. And this is what we call sarcopenia of elderly, right? When somebody is losing their muscle mass because they're in the hospital for 4 days, once the 4 days hit, they have to go to rehab after that because they have lost almost 50 to 70% of their muscle mass. If you ask that same person to breathe this way, it is going to be difficult. They're not going to be able to do it well enough because now they've just spent 3 to 4 days in the hospital and they're tired. They're going to get tired. So we have to do things like adding different supplements, adding different peptides, adding things that will increase their recovery speed for first 2 to 3 weeks really fast while they have the right amount of amino acids and fats and carbs that are placed inside their body during that recovery phase. I think that's the most important part. Recovery can absolutely get better. I mean, I see this all the times.
So this brings up a big question for us.
Yeah.
When you see patients that are recovering from hospital stays, or in our setting, people that are recovering from surgery, how do you, a lot of our discussions with patients is preoperative. You want to optimize protein intake, decrease processed foods, increase your complement, fruits and vegetables.
Yeah.
But we don't really have a meaningful post-operative recovery conversation with regard to diet and supplements. How do you counsel patients when it comes to the recovery phase?
Yeah, so majority of my patients have already done micronutrient testing and food sensitivity testing. I mean, that's the first thing I do in all of my patients, including the genetics. Like those 3 tests are right off the bat that I've been doing it for past now, like at least a year now. And last year or a year before, like when I started seeing you, I was just an offer. It wasn't a mandatory thing. Now it's like everybody has to do it. So I get their baseline done. And now if something happens to that person, I already know that I have worked on this patient for a while to remove their senescent cells. Now, let's say that somebody comes to see me after the surgery. Right away, I'm going to look at their basal metabolic rate because doing the labs is going to take at least 3 more weeks to get the lab results back. So I'm looking at their basal metabolic rate. I'm looking at their past medical history. If any other labs that show me, CBC can tell us whether somebody has parasites or inflammation, right? Some of the ranges can be indicative of some nutritional deficiencies as well, such as B12, vitamin D, magnesium. So these things are really important in boosting somebody's recovery. So if I have those, great. If I don't have it, I know for sure that I want to increase all the cofactors in their body because the body is asking for resources. I'll look at how many days they've spent in the hospital. If it's 1 day, 2 days, then I already know, okay, this person was 150 pounds. Now they are 150, but they've spent 4 days in a hospital. That means they just lost 30 to 50%, maybe more percentage of muscle mass. So then we have to calculate that we need to increase their muscle mass. We need to increase their protein intake.
Why do we lose muscle mass so quickly in the hospital? Is it the fact that their patients are laying down, the recumbent?
Yeah, it's the inactivity that makes them lose the muscle mass. It's like for you and me, right? You might have noticed that when you're sleeping in your room, and if the room is really cold, right, you'll wake up the next morning with some muscle aches and back pain, or it will be just tight.
Yeah, that happened to me last night.
Yeah. So what happened there? Within 8 hours of laying on a bed with a cold environment, our muscles already started breaking down. If you multiply that times 24 with just barely few trips to the bathroom, that will definitely start breaking your muscles down because now there's no more movement, right? Our body instantly starts noticing if you use something, if I keep working out, it will grow it. If I stop working out, if I'm not using them muscles, the body sends a signal and says, okay, you're not using it. I don't need it. Let me move it. Now, combining that with stress of being in the hospital, our body needs enough amount of proteins, right? How many people actually are pre-treated with enough proteins, right? You're giving them recommendations, but everybody doesn't do that, right?
It's very difficult actually for patients.
And to calculate them, right? We need when 5 years ago, I didn't used to tell my patients nor I calculated their protein intake, right? If you're 160 pounds, I know that you're going to need somewhere about 80 grams of proteins a day. And if that person's going into the hospital, I didn't tell them that please make sure that you have 80 grams of proteins throughout the whole hospital stay as well. And they're getting food in hospital from the cafeterias and sometimes it's not enough in calories, even if you're giving them certain amount of protein shakes and shores and all of those things. So we know that transportation system for the hormones in our body is proteins. Testosterone, sex hormone binding globulin. Thyroxine binds to thyroglobulin. All of estrogen binds to estrogen or another binding globulin that we have. I'm forgetting the name of it. But hormones need proteins to travel and be active. Otherwise, they're not going to be transported in the body. So if we're under stress, what goes up in our body? All the hormones. As soon as you put somebody in stress, their hormones go up. Well, they're going to need all the proteins. If you don't increase their protein intake, the body's going to eat you up, break down your own proteins to help those hormones transfer. And it just gets multiplied during the hospital stay, and combining that with antibiotic use.
Yeah, that's why it's such a big reason for our breast reconstruction patients where we'll do a microvascular tissue transfer. You know, we want them up out of their bed post-op day 1. We want them walking around post-op day 2. We're trying to get them home post-op day number 3. And it has not only to do with the risk for a deep venous thrombosis or a pulmonary embolus, but exactly as you're saying, this muscle wasting piece.
Yeah,
prolonged. Yeah, absolutely. So it's nice to hear you say that because it's been a part of our strategy for so long. And I think it does have benefits beyond just the thrombosis piece.
Sometimes if you already know that some patients who don't have cancer or any of those risk factors, then certain peptides can really help boost up, like GHKCU can help them boost up, ceramorelin that, we
talk a bit about peptides. You and I have talked about peptides quite a bit, but tell people, maybe give them a little primer. What is peptides? What is peptide therapy?
Okay, so peptide is a amino acid sequence. Okay,
protein, essentially.
A protein, exactly. Insulin is a peptide, right? Our pancreas, our organs, each organ produces thousands of proteins. Insulin is just one of them. Glucagon is another. There are different, all of these can be different types of peptides, which are amino acid sequences. I'm pretty sure glucagon is one of them. But what happens is our body uses this protein. So first of all, DNA will get read, and then RNA will get read, and the protein will come out, and protein will go out of the cells and go to wherever it's supposed to go into the body and produce an effect. And insulin gets released from the pancreas, but it has effect everywhere in the body. So scientists for the last 50 plus years, they have found many, many different insulin, was discovered in 50, 60 years ago now. And there are many of these peptides that are available and that we're using to help our body get the effect right away. Because what we put in our food, let's say I eat something, my body still has to break my food down into micronutrients, into single individual amino acid.
Sure.
Once it goes inside the blood, inside the liver, then our body says, okay, I need this peptide, I need this peptide, I need this peptide. What do I have at my disposal? Which amino acids are available? Let me put them into different sequences and have an effect. That's a work that body has to do to get to that point of producing a peptide in the body. What we're now looking at is, why don't we just give people the peptide so that it can modulate the immune system, it can modulate your pretty much many of the activities that we do.
Doesn't that peptide get broken down just through digestion to a point where it's maybe not as active, or am I not?
Yeah, so that's why there are different modes of administration. If you take orally, then it may get digested. But if it's an oral peptide, then you take it orally. A lot of them are sub-Q injections because they go directly straight in so they're bypassing the first pass effects of liver and gut and intestine digestions, avoiding all those other enzymes that can break down those proteins. There are some topical ones to boost a lot of the tendon recoveries, muscle recoveries, scar tissue recoveries, post-op surgical recoveries. For hair, there are a lot of those that we have. For sexual enhancements, there are peptides for those. So now we have, more than 100 peptides that are out there that are drugs. Obviously, they're compounded in a pharmacy. They have to be prescribed just like any other drug. So they're definitely drugs. I went through International Peptide Society and A4M, Anti-Aging and American Academy of Anti-Aging and Regenerative Medicine. I went through their courses for certifications for being a peptide doctor. And there's another SSRP group. That's another certification for peptide. They have probably the top 200 peptide doctors in the country in the group right now.
So this is essentially a class of medicine that is evolving? And is it fair to say it's more of a natural pharmacologic mechanism than the medications that are more traditionally used?
Both of them are accurate statements because both type of medicines can be considered natural. But what happens is conventional medicines, we focus on receptors. In the way medicine, the entire medical world is evolving into proteins. Let's look at the proteomics. Let's look at the genetics, right? How does which genes produce which proteins, and then measure those, because there are way too many receptors that each one of these molecules will affect. So if I'm taking an alpha blocker, well, it's going to go into 5-6 different areas in my body and have effects from my eyes to my prostate, right? So I'm taking it for blood pressure. Well, I'm not taking it. But, what I'm saying is, if you're looking at receptors, then there are receptors everywhere in the body, and that's where we get a lot of side effects. If you're looking at the proteins, then you and I both know insulin doesn't have any other side effects other than what insulin does.
Sure.
Insulin doesn't cause heart attacks unless you overdose it, unless, somebody's cholesterol and fat goes through the roof from taking insulin and they're predisposed to having those symptoms. It doesn't cause acute kidney injury. Those are no anaphylactic reactions from taking insulin unless if there's something additive in it that will cause it. So we don't see that many side effects from...
So it's more targeted, in other words.
More targeted.
Yeah.
And they do come, most of them, maybe only a couple of them that I've heard in the world of peptides that come from animal source. Almost all of them are plant-based. They come in different types of powders and liquid. Then the pharmacies will get them, and the pharmacist will work to put them into different formulations. So let's say that if I'm a pharmacist, I will get a powder from some company that makes, these are FDA-approved companies that will make the peptide powders, and pharmacies will get them. They will put them into liquid form, they will put them into cream form, they will put them in the capsule form, they may even put them into a injection form, into different dosages, just so that we are able to get them. And there are a lot of thoughts that go into in terms of how you make things bioavailable. How do you increase their shelf life? Because these things have certain pH, certain acidity level, certain temperature control environment that you have to keep. Otherwise, they start disintegrating, just like any other proteins that you would see in your kitchen. If you don't control the temperature and the environment, they will start breaking apart.
Yeah.
Yeah.
Well, I mean, we could talk about this, I think, for another several hours. I feel like we've only scratched the surface, your expertise here, but I think there's a lot of good information for patients, whether it's techniques to improve your breathing or understanding some of the role of peptides in recovery. So thank you for all this information for our patients. Where can people find you if they want to learn more about your practice and kind of how you approach patient care?
Yeah, so we have a website, aceintegrativehealth.com. It's ACE integrativehealth.com. If you look at profile pages for all the people who are in our team, there are different videos that we have posted on our websites that you can listen to them. We have our phone number, 513-280-8891. You can call our phone number or email us at getintouch@aceintegrativehealth.com. We have been combining IV therapy, stem cells, peptides, all pretty much anything and everything that comes, aesthetics, enhancement of sexual health. There are a lot of things we can do, but my bread and butter is reversing chronic diseases and helping people solve their mysterious conditions. So that's been the most rewarding.
Well, you heard it here. He's the doctor's doctor. He's my doctor. This is Dr. Choksy and Dr. Tiwari signing off for the best podcast ever. Thanks for joining us, and we'll see you next week.
Hey, thank you so much for everybody, and it's been a pleasure.
Thanks for listening.
We hope you found this episode helpful.
Want more info? Connect with us at mwbreast.com.
And go behind the scenes with us on Instagram at mwbreast. Thanks for tuning in.
And join us next week.